All right, good afternoon, everyone. We're going to go ahead and get our programming started. I just want to thank everyone for joining us today for Meliora Weekend and for this specific event. It's an honor to be with you all. My name is Jennifer Strapay. I am the current president of the School of Medicine and Dentistry Alumni Council. I graduated from the University of Rochester in 2016 with my PhD in neuroscience, and I'm now down at St. Jude Children's Research Hospital in Memphis, Tennessee. It is honored to have Dr. Philip Greenland, class of 74 and 78 residency, and the 2018 Distinguished Alumnus Award recipient give this afternoon's lecture. Dr. Philip Greenland is the Harry W. Dingman Professor of Cardiology, Endowed Chair, and Professor of Preventive Medicine at Northwestern University Feinberg School of Medicine. He's also a visiting scientist in cardiovascular epidemiology at Clalit Research Institute in Israel. Dr. Greenland received his bachelor's degree cum laude with highest honors in chemistry from Williams College in 1970. He then earned his Doctor of Medicine from the University of Rochester School of Medicine and Dentistry in 1974 and completed his residency in internal medicine at Rochester Strong Memorial Hospital in 1978. Dr. Greenland's research has helped to shape cardiovascular care guidelines around the world. His work, which has been cited thousands of times, was among the first to reveal that women are more likely to die from heart attacks than men, and his studies illustrated the major risk factors are almost always precedent of heart attacks. He has also contributed to enhanced diagnostic and preventative care, showing the importance of coronary calcium scanning for cardiovascular disease risk prediction. Dr. Greenland has authored over 260 peer-reviewed publications, 120 editorials, reviews, scientific statements, and letters, and 24 monographs and book chapters. He currently serves as the senior editor of JAMA, the Journal of American Medical Association, and was the former editor-in-chief of the Archives of Internal Medicine. Please join me in welcoming the distinguished Dr. Phil Greenland.
Well, thank you, Jennifer, for that generous introduction, and it's really terrific to have this opportunity to be back here in Rochester and to receive this award, which is also a little overwhelming considering all the wonderful, amazing graduates of the University of Rochester that could have gotten this award instead of me. So it's really terrific to have this opportunity and to see familiar faces here as well. So quick outline of my talk. Part one is a little bit of memories. So I'm going to go a little walk down memory lane here, and part two is my research, and that's it. That's the outline of my talk. But I want to thank a bunch of people while I'm here, because, I mean, this is not just an ordinary kind of grand rounds. This is an opportunity to think about the University of Rochester and what it's meant to me and my family. So first, my parents for the encouragement that they gave me and the financial support. To my wife, who wanted to be here, but she stayed behind in Chicago because our daughter was expecting a baby that came this morning. So grandchild number 15 was born this morning at 1:45, and I don't know her name yet. To the U of R for really not just an education, but providing a lifelong opportunity, which I'm going to talk about a little bit more here. And then I just want to recognize a few people that were the giants in my U of R life. My medical school mentors who are listed here, some of my residency mentors, including Dr. Griggs, who's here, some of my mentors when I was on the faculty here, in particular Dr. Greiner, Dr. Yu, Bill Hood, Bob Berg, and Art Moss in particular. Some of my faculty colleagues and staff that were really instrumental. And then my colleagues at Northwestern for the last, it's been 27 years since I left here, Jeremiah Stamler and my current colleague, Don Lloyd-Jones. The research I'm going to talk about here has been funded by the generosity of the taxpayers through NHLBI and from the American Heart Association. And I also want to again thank the Alumni Association for this recognition. So some memories. For those of you who don't know Latin, this is what alma mater means. We say it's you're the school that you graduated from, but the Latin means nourishing mother, and I think that's how I feel about the University of Rochester in my experience. That it gave me the preparation to go on and have a life in medicine that really has wandered from internal medicine to cardiology to epidemiology to preventive medicine to health policy, to administration and a number of other things. So it's been a fantastic preparation for all of that. Why did I come to Rochester? So my first visit to Rochester looked like that. The sky was blue. The trees were autumn, fall foliage. This building, the chapel on the river campus, had just been completed, and it's gorgeous if you've never been inside of it. And I was coming from Williams College to this. I said, hey, this is going to be great. I never thought that winter would come. I met my wife here. This is my mother and father and me with the long hair and my wife in 72. This is where we lived after we got married on Raleigh Street. The one on top is my medical school class. The one over here is my second year residency. And this is me right here. When I came back on the cardiology faculty, and I first grew a beard back then because all my patients thought I looked too young to be a doctor. And the beard made me look a little bit older. Now, well, you know what they say. And after residency, I moved to Minnesota, where the weather was not much better than here. And what I didn't know about Minnesota was that the summers were also horrible because of the mosquitoes. So things surprise you. But I came back to Rochester. We lived in this house on Warrington Drive. And these are some of my colleagues, particularly Jeff Levenkron, who looked the same back then as he probably does now. And my parents used to visit all the time and take the kids. Our 4 kids were born here, all of them. And these are my 4 kids today. This one is this one. This one is this one. That lady is the mother that had the baby. This is Aviva. And that guy up there is my son, who's the guy on the right over there. Okay, enough for the memories. I'm going to talk a little bit about the research here. And, the title of this was An Unexpected Career in Preventive Cardiology. And the unexpected part was not necessarily the cardiology or the preventive part. It was the research part, which if you had asked me when I came to medical school, do you want to have a research career, I would have said no. I came to medical school knowing very little about medicine. There were no doctors in my family. The only thing I knew about medicine as a career was that I had had an illness myself when I was 13 years old. I became very close to my pediatrician, and I wanted to be a pediatrician. I wanted to be just like that doctor. So Larry Nazarian, you're probably asking, why didn't you become just like that doctor? And the answer was basically inpatient pediatrics. That was the end of it for me. If I had seen outpatient pediatrics, I might have chosen a different path. But back in the day, we mostly saw inpatient pediatrics and really sick kids. And that was the end of it. So I went into internal medicine. And during my residency, I got exposed to research. And I'm going to tell you a little bit about that. But the 5 areas of research that I'm going to talk about today are areas where I've spent some of my time over the last 30 years. So I'm going to talk a little bit about heart disease in women and what we've learned about that. I'm going to talk about some aspects of cardiovascular risk factor exposure that I think were not totally understood and are now very well understood. And I think you'll see what I mean by that when I get there. I'm going to talk about what we're now defining as ideal cardiovascular health, which is a term that the American Heart Association has adopted and really promoted and made a big deal of. And our research from Northwestern has really influenced that decision quite a bit and that strategy. And then I'm going to talk about some work that we've done over the last 10 years on early detection and about coronary imaging, and maybe a little bit about the future. So the first exposure to clinical research that I had was in residency with Dr. Griggs. Just a little anecdote about that. You may remember that in the late 70s, we had a Guillain-Barré outbreak. Some of you that were around at the time. There was a Guillain-Barré outbreak in upstate New York, and we had many of those patients come here to Strong Memorial Hospital. They ended up, many of them, in the intensive care unit, and when we were following them in the intensive care unit, we noticed that many of them had arrhythmic complications of their hospitalization. And this was not previously reported in the literature, and Dr. Griggs and I collected the cases. We did what you did back then. You reviewed the paper charts and collated the data, and we put it together as a paper that we sent to Archives of Internal Medicine. I don't know if Birch remembers this, but we sent this paper to Archives of Internal Medicine in the era when you packaged it all together as a bunch of paper, stuck it in an envelope, and then about, a month or two later, you got another envelope back with the reviews. And we got a letter back that said something like, "Dear Dr. Greenland, we've reviewed your paper and we're accepting it. Thank you for your submission." Right, end of story. No request for revisions, just thank you. We're accepting and publishing your paper. So I thought, hey, this is pretty easy. You review a bunch of charts, you write it up, you send it in, they accept it, and you go on to the next. That experience of getting a paper accepted on the first submission has happened to me one other time in 30-something years of doing research. But that got me enthusiastic about thinking more critically about what we do with patients and how we understand what we're doing with patients. And the next exposure was when I came back on the faculty, and many of you will remember that Paul Greiner was very interested in promoting the idea of critical decision-making and quantitative medical decision-making. And we had this very large monograph in Annals of Internal Medicine, and that went on to become a book, which somebody told me last night, oh, there you are, that they still have it on their desk and read it. I have it on my shelf at home. I haven't pulled it off the shelf in a while, but maybe I will. So Paul Greiner was an inspiration. Birch Griggs was an inspiration to me. The third paper there is something that I put up because my fellowship in cardiology, what I was interested in at the time was atrial fibrillation and stroke. And the interesting thing about that is I totally dropped that area from 1970 something until now. And my most recent grant is on atrial fibrillation, atrial myopathy, and brain infarction. So that's some of my current research. And while I was here on the faculty, the other area that we were working on was trying to get medical students to be more proficient at behavioral counseling skills, and we got some grants. Jeff Levenkron and I received some grants to improve the curriculum and wrote a bunch of papers on that. We also had a grant here in the 80s on cholesterol screening. Some of you may remember this. We had a partnership with Wegmans, and we were doing cholesterol screening in the supermarkets in Rochester in the 80s and wrote a bunch of papers on that. But the thing that really, I think, triggered the next 30 years of research was this paper right here. In 1989, I took a sabbatical, and I went to Israel for the year, and I was exposed to an opportunity. I was given an opportunity to work with what we would have called in the day big data. Today, we would call that trivial data, right? But back in the day, 6,000 people was a lot of data. And this was an entire population-wide database of myocardial infarction patients, men and women, experiencing myocardial infarction in all of the coronary care units in Israel. And the question we asked was just a simple question. What are the outcomes after myocardial infarction in men and women, and are they different? And when we studied this, we found, and many of you probably know this, that actually the outcomes back then anyway for myocardial infarctions were worse in women than in men, partly because of the older age that women have heart attack. But even after you age stratify, the outcomes were worse, and that led to a whole line of research on heart disease in women. And I continued to study that area when I moved to Northwestern. This was one of our papers that was published, I think, in JAMA in 1998. And eventually, all of that line of research led to much greater recognition of heart disease in women and the Go Red theme of the American Heart Association, which I feel like my work, other people's work, really contributed to this recognition of heart disease in women. So that's one area that I felt like we really made a big difference, and now it's part of the normal approach, the normal way of doing business with heart disease prevention. It's an equal opportunity disease, and men and women are getting attention, I think, in ways that they appropriately should. The next area of research that I wanted to just highlight a little bit is that we started getting interested, I think, really for the first time in trying to understand not only why certain people have high risk, but why some people have low risk for heart disease. And we had a number of databases in Chicago. One of the things that happened to me when I went to Chicago is I hooked up with this man, Jeremiah Stamler. Dr. Stamler was one of the pioneers of cardiovascular epidemiology. He practices what he preached. He's 98 years old, Jerry. He's still doing research. He still has 2 NIH grants at age 98. And his brain is healthy and his heart is healthy. And if only his orthopedic life was healthy, he'd probably be running marathons. But one of the things that Chicago had done in the 60s and 70s was some large projects screening fairly large numbers of people. And there was a project that had been done in the late 60s, early 70s, screening 40,000 people in Chicago. And we were able to link up those data from the 60s and 70s with their Medicare experience up through the 90s. And we published this paper, I believe this was around 1998 in the New England Journal of Medicine. And what we were interested in looking at was the experience in terms of healthcare costs of people who had had favorable cardiovascular risk factors in early life and what the outcome would be in terms of medical care experience years and years later. So I highlighted a few things that I wanted to just mention here. There were, of the 40,000 people, there were a relatively small number of people who had cholesterol level less than 200 plus, systolic blood pressure 120 or less, and diastolic 80 or less, and not smoking, and had no ECG abnormalities, no history of diabetes, no history of myocardial infarction. So of the about 7,000 men and close to 7,000 women, you can see that only 4% of the men and 4% of the women had all of those factors favorable. And of those 4% who had all of those factors favorable, when we looked at their Medicare experience, their healthcare charges, including the last year of life, and excluding the last year of life, right? So the last year of life, we know, adds tons of medical care costs. But if you exclude the last year, those people still had less healthcare costs. And we've gone on to look at their experience in terms of physical function, cognitive function, other aspects of their health experience. And these relatively small numbers of people who have all the cardiovascular risk factors favorable live longer, have less disability, lower healthcare costs, less likelihood of cognitive impairment or dementia. So this line of research went on to influencing the American Heart Association to adopt this classification of healthy people as ideal cardiovascular health. And this was it's the policy of the American Heart Association at the present time. So let me just take you back in history a little bit. Nowadays, you would say that heart disease is largely preventable, and yet largely preventable heart problems are still killing large numbers of Americans. And this was written up in this ACC News thing that I got a few weeks ago. And everybody knows that heart disease has these risk factors and heart disease is preventable and so on. But just as a reminder, there was no such thing as the concept of preventive cardiology before about 1950. No one actually thought you could prevent heart disease. The general concept was that it was an inevitable consequence of aging. People referred to it as arteriosclerosis, if you remember. And the concept of risk factors and preventable interventions was unheard of. And I'm going to prove that to you. Here is Samuel Levine's textbook of clinical heart disease, published in 1946. And this is the index. And right about here, you would expect to see a word like atherosclerosis. It's not there. And right about here, you might expect to see something like, arterial something or other, not there. And right around here, you would expect to see a word like prevention. It's not there. And even the great Paul Dudley White, who was an incredible champion eventually of cardiovascular disease prevention. Some of you probably trained in Boston at somewhere along the line and knew Paul Dudley White, who would tool around Boston in his bicycle and his dress clothes. And Paul Dudley White was President Eisenhower's cardiologist. He was unsuccessfully getting President Eisenhower to stop smoking. And we all know Eisenhower died of myocardial infarct, about his third myocardial infarction. But in the history of describing myocardial infarction, Henry Blackburn, who I'm going to talk about in a few minutes, wrote that in hindsight, discussion of either the pathogenesis or the treatment of coronary heart disease was conspicuously absent from the great classic texts of cardiology until Paul Dudley White in 1941, and even White, as late as his third edition in 1948, makes no mention of prevention. Eventually, Paul Dudley White said a heart attack after 80 is an act of God, but before 80 is a failure of medicine. And Paul Dudley White eventually was a big advocate of regular exercise and the establishment of cardiovascular epidemiology. A reminder, see, this work, yeah. So again, a reminder here, the cardiovascular disease epidemic in the United States peaked around the 1950s. And it was right about here, after World War II, that the National Heart Institute was established and the Framingham Heart Study was initiated. And this was really the beginning of the idea of studying cardiovascular risk factors, and we know that there's been a big impact of this over the last 40 or 50 years. But prior to this, most clinicians, as I understand it, were largely unaware that there were risk factors and that there were ways to potentially intervene. Just a little aside here. Turns out that the risk factors were actually described before the 1950s, not by cardiologists. Anybody want to hazard a guess? Who knew that hypertension was a risk factor for heart attack? Who knew that cholesterol was a risk factor? Who knew that cigarette smoking was a risk factor? The life insurance companies. So if this minor library still has books, do they? Does the minor library still have books? Okay, so you can look up life insurance medicine from the 1940s, and you'll see that the life insurance companies had risk tables that showed clearly that hypertension was a risk for myocardial infarction, cholesterol was a risk factor, and cigarette smoking was a risk factor. And I learned about that because Jennifer mentioned that I have an endowed professorship at Northwestern called the Harry W. Dingman Professor. And when they gave me that professorship, I asked who Harry Dingman was. And it turns out Harry Dingman was a life insurance doctor. He worked for the Continental Life Insurance Company in Chicago, and he wrote a book in the 1940s that has all of this information in it. So they knew before Framingham. Anybody remember when the first Framingham paper was published? 1961. So, and the Surgeon General's report about the health risks of cigarette smoking and lung cancer was in the 60s as well. So it really took kind of the established medical community till the 60s to start appreciating this. But, okay, so I've got some of this here. The first Framingham paper was 1961. And this is a graph from that first paper in 1961 in the Annals of Internal Medicine. And what it shows is kind of interesting, especially considering the lack of interest in low risk. Because what it showed was that from a serum cholesterol of about 150 upwards, the risk of heart attack, no matter what your systolic blood pressure was continuously increasing. So when I was a medical student, we were concerned about these people. And if you look back at some of the textbooks at the time from the 70s, the only textbooks that really talked about heart disease risk factors were endocrinology textbooks that were interested in familial hypercholesterolemia, cholesterols of 300 and so forth. Whereas today, as we all know, we're paying attention to cholesterols down here and blood pressures down here and so forth. But it took quite a while to get people concerned about that. And when I was still in residency, what most of us were taught was that the risk factors have been demonstrated to be associated with heart disease, but so what? That's what we were kind of being taught. And this is an editorial from the American Journal of Cardiology, which at the time was the official journal of the American College of Cardiology. And this guy, Elliot Corday, was the president of the American College of Cardiology, and he wrote this editorial where he said, it's time to get real about these risk factors. They're interesting, they're descriptive, but they really don't mean anything in terms of treatment. And that's kind of what I was learning, not because we were behind the times here, but that was the prevalent idea. So fast forward a little bit. The first studies of successful treatment of hypertension were beginning to come out at about that time. And that initiated those initial trials where we were treating diastolics of 110 and showing that by treating diastolics of 110 with medication, you could reduce the risk of stroke. That information led to this first Joint National Committee on High Blood Pressure Treatment. And this was all coming out when I was a first-year resident. My fellowship was at University of Minnesota. And many of you probably know this. Ansel Keys was doing heart disease epidemiology research at the University of Minnesota in the 60s and 70s. And by the time I got there in the late 70s, his successor, Henry Blackburn, had taken over. This is Ansel Keys in his later years. And this guy right here is named Russell Lupker. And Russell is also a medical school graduate from the University of Rochester. Same class? Yeah, same class. So Russell was an assistant professor. Yeah, which class was he?
He took a year out, and so he'll come next year.
Okay, so Russell was like 6 years ahead of me, and he was an assistant professor when I arrived at the University of Minnesota. They used to have their lab, by the way, in the football stadium. So they were sort of marginally on campus. That's how much the University of Minnesota valued their research at the time. But as we all know, that research, which was known as the 7-country study, was led by Ansel Keys, and that Ansel has been widely recognized not only because of his heart disease research, but he was the guy who invented the K ration. Okay, and that's why it's called the K ration, because his last name was Keys, and he named it. And this is the people that have been honored with the Ansel Keys Lecture by the Heart Association, and that guy's me right there. And Russell is here, and Henry Blackburn is here. And this is a big honor to have been given the opportunity to give the Ansel Keys Lecture a few years ago. So the next step in the story was the demonstration that lowering serum lipids actually mattered. And again, many of you in the room will remember this, that the first demonstration of that in humans was the Lipid Research Clinic's coronary primary prevention trial, which was published in 1984. And this is the survival curve. This is the occurrence of cardiovascular events in people treated with placebo. And this is the survival experience in people treated with cholestyramine. How many people remember cholestyramine? Okay. My patients used to refer to it as sand. Okay. You know, that's what we used to treat high cholesterol with. But this study was a landmark study because it proved in humans that even if you gave them sand to lower their cholesterol, if you lowered their cholesterol, it would reduce the risk of first myocardial infarction. I was really fortunate because at the time that this came out, I was back in the faculty in Rochester, and I got my first NIH grant here. In 1985, I got a Career Development Award in preventive cardiology, and I had the good fortune of meeting Bob Levy, who was the director of the National Heart, Lung, and Blood Institute, a famous cholesterol researcher and the person who really pioneered this study. And then we got the grant to do this cholesterol screening project with Wegmans in 1986. And from my point of view, we transitioned in 1985 from epidemiology to preventive cardiology. We went from understanding that there was an association between the risk factors and development of heart disease to an understanding that intervention would actually prevent heart attacks. And that was, I would say, the birth of real preventive cardiology. And in that same year, cholesterol got an incredible amount of attention because Brown and Goldstein got the Nobel Prize for their landmark work on the LDL receptor. And that shortly afterwards led to the first national program on evaluation and treatment of high cholesterol in 1988. And I just want to, for history's sake, remind you that when this first one came out, what we were saying was that we would be satisfied with a cholesterol, an LDL cholesterol of less than 160. So as long as the LDL was not greater than as long as the LDL was not greater than 160, clinically we would be satisfied. And today, Ron, what are we saying we're satisfied with? 50, maybe? Okay, so this whole field has totally changed in 30 years. I was trying to think back. If you had asked any of us in 1988, what would we consider an ideal cholesterol to be? I don't think we would have said 50. Maybe we would have said 50, but we wouldn't have been very confident about it. But now we're actually pretty confident that something in the neighborhood of 50 to 70 is probably the ideal and probably what we should be trying to achieve. So again, a few years later, Brown and Goldstein had this really interesting editorial in Science. And they were reflecting on the fact that from the time that we understood the LDL receptor, which led to a Nobel Prize in 1985, the statins had been developed. The statins were dramatically lowering cholesterol, and they enthusiastically said that there was a real possibility that heart attack would be completely wiped out by the year 2000. What did they miss? They missed the year, yes. What else did they miss? Patients don't necessarily do what we ask them to do, right? So what they said in this editorial was really interesting. That heart attack will likely lose its notoriety early in the next century because we now understand cholesterol and lipoproteins. That's true. But we didn't necessarily understand patients. And we're still trying to understand patients, and we're still trying to understand how to get more patients to actually get into that low-risk category, which is what we've been devoting a lot of time to over the last 15 or so years. But they did endorse the idea. They did endorse the idea that it was really important to get on prevention and not just treat the highest risk patients. So that was, I think, a really important observation. Statin trials we all know about. I don't want to spend a lot of time on it because we all know about the statin trials. But, I feel like we made this gigantic leap forward with the statins. It's going to be interesting to see whether we make an additional leap forward with the PCSK9 inhibitors. But I'm going to come back to PCSK9 inhibitors in a little while. So I just said that we spent a lot of time in the last 15 years thinking about how to get more people low risk and what it would mean if more people were low risk. So we took advantage of the fact that we had some fairly large population studies that had been going for a very long time in Chicago. And we looked at the experience of additional groups of patients who had these low-risk characteristics that I was talking about before. People who didn't have ECG abnormalities and people who had favorable levels of cholesterol, body mass index, no diabetes, and no smoking. And this is what we found in the survival experience. People who had no risk factors are down here, and people who had 1 or 2 risk factors are up here. So in other words, not only do these risk factors predict at the high risk level, but people who don't have the risk factors are largely protected. And we've now confirmed this not only in the Chicago studies, but in the Framingham Heart Study, the multiple risk factor intervention trial, 362,000 screenees. We've confirmed it in every study that we've looked at. People who don't have risk factors for heart disease don't get heart disease. So what's the problem? I showed you earlier, only 4% approximately of Americans have no risk factors. So we got to figure out how to get more people in that category. A second thing that we were interested in trying to demonstrate, and again, some of you will probably remember this very, very clearly. The textbooks of cardiovascular medicine used to say that only half of patients who had heart attacks had risk factors. Anybody remember that? Okay, that's what they used to say all the time. The textbook said that. We were all taught that. So I don't know when it finally hit me, but I started thinking somewhere around 2000, it took me a long time for this to sink in, that if half of all people who had heart attacks didn't have any risk factors, the implication of that would be that the risk factors actually protect you from having heart attacks as opposed to cause the heart attacks. So I said, this doesn't make any sense to me. Do we have any studies that would allow us to look at antecedent exposure way before heart attack? And let's look and see how many of them actually had at least one risk factor. So I'm just going to show you an example from one study. This is actually from the Framingham Heart Study. And this is actually people with at least two risk factors, not one, but at least two. And we looked in Framingham at men in younger age, men in what might be called middle-aged, women in younger age, women in middle age. We looked at CHD death, non-fatal infarction, and people who didn't have any of those in follow-up. So in Framingham, the younger men who had heart attack, and we're not talking very many of them, 95% of them had at least two risk factors before the heart attack. Not half, 95%. The middle-aged men, 94% of them had at least two major risk factors before they had a heart attack. So we were demonstrating that not 50%, but close to 100% had at least two risk factors demonstrable before the heart attack. But the kicker was that when we looked at the people who didn't have a CHD death, 70% of them also had at least two risk factors. So this paper, which we published in JAMA in 2003, this has been cited about 500 times, this work. And at least in our opinion, it really completely changed the thinking. I only occasionally see people repeating that mistake about only half of heart attack patients have risk factors. There was an editorial at the time in JAMA claiming that we had finally once and for all debunked the only 50% myth. And as I said a little bit earlier, where this has led is to a report in 2010 by the American Heart Association defining this new strategy of trying to call out and identify the need to get more people in the category of having no risk factors. They defined that category as ideal cardiovascular health. And since this report in 2010, I've been able to find at least 500 papers in the medical literature using this concept of ideal cardiovascular health. It's been associated with lower risk of heart attack, lower risk of stroke, lower risk of cognitive impairment, lower risk of all cancer combined, lower risk of kidney disease. So it's really powerful, and at least to some extent, we feel like our research has contributed to establishing this as a health policy. Okay, the last thing that I want to talk about, and I do want to give time for questions, so I'm not going to go into too much detail about this, but to say that the next thing that I personally got interested in was the challenge of trying to identify cardiovascular risk earlier, and to try to help sort out that problem that I was showing before, that 70% or so of people who don't get heart attacks also have risk factors. So the risk factors we think cause heart attacks, but they're not very specific. And many people who have those risk factors don't necessarily turn out to have MI. So could you sort that out? And could you figure out which ones are more prone and which ones are less prone? And one of the thoughts that we had and other people had was using CT scan to identify coronary calcium. This is a really bad case where the entire left anterior descending artery is calcified. This is a moderate case, and this is a relatively mild case. And of course, normal would be no calcium at all. And I would have to say that the main reason I got interested in this early on was because maybe this didn't affect Rochester, but this affected Chicago a lot. There was a company in Chicago in the early 1990s called Heart Check America. And Heart Check America operated 2 electron beam CT scanners in Chicago. Does anybody know what an electron beam CT scanner is? So the CT scans that we use now are really fast. They're so fast that you can actually freeze frame the heart and get a reasonably clear picture of the heart by CT. But the CT scanners that were available in the late 80s, early 90s were slow. And the heart moves too fast, and you didn't get a clear image. You got a really fuzzy image. But engineers developed a technique called the electron beam scanner, which operated by accelerating an electron beam in a gantry. And by accelerating the electron beam, they could get a rapid scan that was fast enough that they could freeze frame the heart and come up with these images of the arteries and quantify coronary calcium. The problem is there was no research on this, and the instrument cost millions of dollars. So what they would do was they would run ads in the Chicago area on the radio, which I heard every day riding to work. And they went something like this. They said, I saved my husband's life. My husband's a 50-year-old man who thought he was completely healthy. He had no heart risk factors, which we know doesn't happen, right? He had no symptoms, but for his 50th birthday, I sent him to Heart Check America. And they found that he was a ticking time bomb. Okay? That's what they said on the ads. And that he ended up going to have bypass surgery and so on and so forth. I looked up the research on this topic, and there wasn't any. So we got involved in a new cohort study. We recruited 6,000 people in 1990. We've followed them every 6 months since then. One of the outcomes of our research was that the Illinois Attorney General eventually sued Heart Check America and closed them down. That's one outcome. The other outcome is right here, where we showed that when you're trying to differentiate people who are or not going to get a heart attack, the winner by far is coronary calcium over here. This is any other risk factor that you can think of: C-reactive protein, cholesterol, ankle brachial index, et cetera. And a lot of our research over the last number of years has been focused on this area of research. We've demonstrated that people who have no coronary calcium have a much lower risk of heart attack than people who have any of these other risk factors. And to a large extent, this has also influenced medical practice. So I had some slides on the future of preventive cardiology, but this is all speculation. So I think for the sake of time, I'm going to sort of wrap up. That's what we've been doing for the last 25 years or so. I think there will still be a future for preventive cardiology. And maybe if there's a question about it, I can try to address it. Thank you for your attention.
We have time for maybe 2 quick questions. There is some more programming this afternoon. We do have mic runners, so make sure that you receive one of those from them.
So thank you, Phil. That was terrific tour de force. The American Heart Association, 10 years ago, started pushing Life Simple 7. In fact, in neurology at least, since they started doing that, the number of people that are doing Life Simple 7 is worse than it was when they started. So that the question comes up of implementation research. Do you think the country is spending enough doing what National Cancer Institute spends, I think something like 30% of their budget on getting doctors and patients to do what prevents cancer? Neurology Institute spends zero. I'm not sure about NHLBI. But you found what needs to be done. The question is, are we doing a good enough job of it?
Yeah, so coming back to what, that point that I was trying to make about Brown and Goldstein, who are incredibly smart people, I think we have an incredibly good understanding of the science. And we understand what regulates serum cholesterol, and we understand a lot about blood pressure and blood pressure treatment and so forth. But, we have not improved the number of people who are in this favorable, Life Simple 7 category. And, that's, I think, one of the future issues in preventive medicine is trying to reverse this trend that we have of obesity, increased metabolic syndrome, increased diabetes, et cetera, which are, kind of taking things back in the wrong direction. So, yeah, I agree with you. We need to pay more attention to that.
Great talk, Phil. Do you think that we should spend society's limited resources on calcium scans to provide incremental risk assessment? Or, as some have suggested, perhaps we should just put statins in the water supply and provide them more liberally at a younger age? Do you see any downside risk to starting statins in at-risk people in their 30s or 20s?
Yeah.
We have 4 decades of statin data. It seems to me that getting at your very interesting comments about human behavior, I think we understand the science pretty good now. What we don't understand is how to get to patients, how do we modify those behaviors early in life in order to optimize long-term outcomes?
Yeah, well, it's a great question. It seems a little bit crazy, at the outset, not that I'm criticizing the question, it's just, the idea that are in our futility, to have people lead a healthy lifestyle, that we would resort to, the equivalent of fluoridation, for heart attack prevention, putting statins in the water. But I'm aware that there is a proposal that NHLBI is considering of a statin trial in people in their 20s. And the concept, just briefly, the concept is if you could, in today's world, delay the onset of clinical coronary disease by 10 years. Okay, so just picture this. So the average point in life when people are having heart attacks now is around age 70. We've pushed it up quite a bit. So if you could delay the onset of clinical coronary heart disease into the 80s and 90s, people would experience other illnesses as the cause of their death, but not coronary disease. And you could functionally eliminate coronary disease. And they're referring to this almost as a coronary vaccination. Okay? It needs to be tested, right? Nobody would be comfortable giving millions, hundreds of millions of people statins, even though we recognize them as safe and effective. But if that study gets done, and if the study does what it's intended to do, that could be the result.
I want to take this opportunity.
We have one more.
Sure, one more question.
Thank you, Dr. Greenland, for a very clear lecture. Can you comment whether there's any work, either in basic science, epidemiology, or intervention in other countries besides the United States from which we can benefit?
Yeah, absolutely. Absolutely. It's hard to know where to start because there is so much work going on. But one of the most important studies, I would say, along the lines of what Ron Schwartz was just asking about, here in this country, we have a very medically intensive approach to, the cardiovascular problem. So much so that other countries, especially low and middle income countries, can't afford to take the approach that we've taken. So one of the studies that was done recently in India gave low doses of statin and 2 blood pressure medications. Low doses, so low that basically they weren't even followed clinically. The risk factor changes were not tracked. And what was demonstrated was that from this poly pill given to people in India for pennies, you could prevent cardiovascular events. So that's one example. I think there was a similar study that was done in one of the South American countries recently that we published in JAMA. And there's certainly interesting epidemiology from Korea, Japan, China, India, Israel. I don't have time to talk about it, but yes, absolutely. There's really good stuff that we can learn from other places around the world. Thanks for the question.
So I want to take this opportunity to congratulate Dr. Greenland again on his Distinguished Alumni Award, apologies, and thank him for a wonderful talk this afternoon.